I'd like to introduce today's our speaker, also one of my co-advisors. Dr. Kelly Searle is an epidemiologist that specializes in malaria risk in southeastern Africa. She also has an expertise in GIS and spatial analysis to understand environmental factors associated with disease transmission. She has worked in Zambia and Zimbabwe to understand factors associated with ongoing malaria transmission, areas approaching elimination to inform policy at fully interrupting trends in the most efficient manners. When joining the team in the division of epidemiology, Dr. Searle established research in Western Mozambique to investigate malaria risk in areas of persistent high transmission. She has also branched out into investigating environmental factors associated with elevated malaria risk, how climate change impacts risk, and impacts the success of interventions and control programs within this area of change. And I would like to present Dr. Kelly.
I mean, I'm not gonna lie, this was my vacation. So I'm really excited. And I'm really excited about climate change and malaria. And so it's really cool because this is a bit of a new research direction. It still has the malaria, but going in climate change part is a little bit new. And it is a fastly emerging research area and trying to tease out the impacts, the specific impacts that we are seeing and are going to see associated with climate change. And so change is here. There's no kind of preventing. We're in it. So the climatologists have been working for a long time, but it's more that we've been getting into thinking about this health related impacts. And I forget, but we're really kind of on that cusp of measuring this and doing it in a way that we can actually inform policy to be useful, not just say that change is bad. And so this is pretty new in connecting these things, but the Lancet is putting out these annual reports on kind of their countdown to health and climate change. This year, the 2023 report, they lead into the real gloom and doom of it. So from their title, you can see, there's an imperative for this month in a world facing irreversible harm. So they're very clear that we're here. It's no longer about preventing climate. We're here, and what are we going to do about it? How do we mitigate these impacts? And how do we actually form a policy around it so that climate change kind of area has moved out of strictly climatology into public health. And in their report, really, they did a good job of kind of this momentum of how climate change is being perceived at different levels. And so this graph is showing how it is. It's showing the mentions of climate change and health and their interactions at UN general debate. A portion of countries that actually bring these things up. Over time, you can see on the climate change being mentioned more frequently. So people are actually talking about it on that global scale. They also have been talking about health more frequently. The interaction between these things has been lagging behind. And so it wasn't really until 2020, likely pandemic, that this became an actual topic of we need to think about how these things are interacting and how it's actually impacting our health. And so that's looking at a kind of global policy scale, but they all look at kind of the media is covering this. And so newspaper articles that focus on climate change and also focus health and climate change. There's a weird U-shaped curve about climate change, but it is picking up speed a little bit. However, the interaction between health and climate change really isn't getting a lot of media attention. So maybe kind of a little bit on the forefront of policymakers' mind, but in the general population, it's not something that people are generally thinking about. Academically, we are thinking about it, and over the past 20-25, there's been a huge increase in regarding the impacts of climate change. With research around mitigation and adaptation. And that's really important because right now we are in that mitigation and adaptation phase. So going from planning these impacts and then what do we do about this? And so an infectious disease person. So climate change is in effect every area of our health, but I focus mainly on the infectious disease part. And so with infectious diseases, there's really big three that people think about in terms of this is probably going to be impacted by climate change. And one is Vibrios. Luckily, the Vibras, which are real bad, don't seem to be like they're going to be really that much impacted. They're already bad in places where they can. But the non-cholera Vibrios, they were less familiar. These actually live in the ocean, and they're going to potentially affect our coastlines. So the coastlines for transmission of these non-cholera Vibrios is expanded. And so this is of particular interest if you are interested in occupational health for people that use funds for their jobs, or if you enjoy seedy food. And so dengue, just to corner you and talk about anything related to mosquitoes and climate change, I definitely agree with you, but this is going to be a big problem in the future. It's already a problem now in how it's expanding, and it's going to expand. And so this crowd, it's not dengue cases, but it's the percent change in the basic reproductive number of dengue, so the transmission potential, and how much of that has increased since the 1950s. And it's graphed against the mosquitoes that affect it. And so Aedes mosquito vector dengue. They're incredibly invasive, and everywhere they go, they take dengue with them. And they develop in a variety of different environments, but this is increase in their average temperature, they can live longer there, and they can transmit dengue. So dengue is be a really big deal in the future globally. And I saved the malaria for last because we're just going to talk this from here on out. So a lot of people bring up that malaria is probably going to be pretty bad in an era of climate change because it's a mosquito-borne disease, and we really worry about those vector-borne diseases with increasing temperatures. One of the good news is in very high income countries. So this is divided by the Human Development Index, which is mainly derived from income. So in the very high income countries, it's not really seeing much of a change, right? And so in countries, there isn't a, and it's not actually predicted that it's going to become a huge problem in those areas. In just high income countries, there is likely to be an increase. And sorry, so this is graphing out the increase in months of the malaria transmission, how long it can be based on the underlying temperature environment. So how long malaria can actually be transmitted throughout the year. However, in low and medium increase, it is predicted that the time period where it can be transmitted is going to increase. So longer malaria, more malaria patients. This is something that we see and we are seeing really commonly with the health impacts specifically of climate change, is that low and medium income countries are actually experiencing the burden of the impacts in much higher proportion and faster than higher income countries. And so the countries that are least responsible for this problem are already seeing the impacts of it before the higher income countries. And so now that we're on the malaria trend, I talk a little bit about cycle, why it is so temperature dependent, why it is so climate dependent, and why we worry about it with climate change. And malaria is a disease that's vectored by Anopheles mosquitoes. I'm not going to go into the complexity of the entire life cycle, but I'm going to highlight the things that are actually important for this topic. And so you've got a female Anopheles mosquito who's infected with malaria parasites, takes a blood meal from a human, and injects the sporozoites. And so those are the asexual phase of the parasite. They go into the human and eventually they end up infecting red blood cells. Within the red blood cells. So And this is kind of their side. They just keep infecting red blood cells, the red blood cells. And so this is where you actually see this of malaria taking place in people. They get anemia, fever, chills, headaches, and it can cross the blood-brain barrier and reduce oxygen transmission, leading to seizures, cerebral malaria, and ultimately. Some of those parasites differentiate into male and female gametocytes, and those then can be transmitted back to another mosquito, an uninfected mosquito, when that mosquito then bites an infected human. So now mosquito side, because that is really. So mosquitoes are exogenous creatures. So they are very dependent on for their survival. And once they ingest the parasite has to reproduce within the mosquito's guts and transmit to their salivary gland, transmit again. So there's an entire parasitic phase within the mosquito that is also temperature dependent, because it's inside an animal that is dependent on the weather conditions. And so everything over here, the exogenous side of malaria transmission, completely weather dependent. And so within the mosquitoes, you don't have a very complex life. It's pretty. So they emerge out of the water. Their little eggs go in the water, emerge from a pupal state, and right. And as soon as they all these eggs emerge, they swarm, they mate, and that's the only time they're interacting with each other. And females, after that, their entire life goal is taking blood to lay eggs. So in order to lay eggs, they have to take a blood meal. And so they begin searching for a host, they take a blood meal, and the development of eggs that go in a trophic cycle, that is completely dependent, temperature dependent. So it's faster at higher temperatures, slower at lower. And so once they have their blood meal, developing their eggs, then they go lay their eggs, then they go another blood meal to lay more eggs. Right? It's incredibly dull, but it is completely dependent on the temperature and the weather and the availability of water to lay their eggs. Okay, and so this during the sporogonic cycle. So that is the reproduction of the parasite, the malaria parasite within the mosquito. So that's how quickly that parasite goes from ingested, going through the guts, becoming sporozoites, and going up into the salivary glands. And so from these models, focus on the graph on the left, we're going to see at higher temperatures, the sporogonic cycle ends. So the parasites develop faster within the mosquito at elevated temperatures, and they kind of have a sweet spot around 30 degrees. 25-30 degrees is really where they like to be. What's important here is once it goes too high, above 3 degrees, everything dies, right? So at really high temperatures is bad. Really low temperatures is bad. But if you elevate it slightly, just a few degrees, it gets faster. Also, the gonotrophic cycle is saying that egg development within the mosquito, it's quicker at higher temperatures as well. And it sits really nicely on that parasite development cycle, around 30 degrees. Right? And the gonotrophic cycle is actually a little bit quicker than the spore. And so at 30 degrees, those eggs develop in less than can develop in less than 3 days. And so that is the time between that mosquito going and biting another person. So 3 days between those bite cycles. The increase in the parasite development at higher temperature, and an increase in the biting cycles of these mosquitoes. So it's increasing that potential transmission. On top of that, this is really busy, but it's looking at the life expectancy of mosquitoes depending on the different temperatures. And we'll focus, this one's the most easy to read in the bottom left corner, looking at temperatures and the proportion of mosquitoes surviving for a number of days. And so mosquitoes are highly dependent on temperature. And so if you have 20-25 degree range, at these temperatures, mosquitoes have a higher probability of living longer. They don't have long spans, but they have a higher probability of living beyond 21 days. And in that time period, they take a lot of blood. Right? And when you increase the temperature just slightly, you increase the life, so you can increase the lifespan of mosquitoes, you increase the development of the parasites within the mosquitoes, and you increase their biting rate. And so all of this potentially leads to more malaria, right? And so this is a really cool study where they modeled out the impact of climate change on the global distribution of malaria. And I'm not going to go through the specifics of their model, but just show kind of their main results. So they did different types of models, and one of them is called miasma, which is really cool. But they did these different types, and they looked at globally what the change in months is in terms of transmission season of malaria. How much longer can it be globally? And in some areas, it's to be a longer transmission season, and in other areas, it's expected to be a short transmission season. And the ones come mainly where they show in the very, very tropical regions. And that's because it really does, it reaches that point, it's too hot and everything dies. And so this can't live, the parasites can't live, it's just not very livable. Which is news for humans either. So it's not like, oh, there's no malaria there, let's do it. It's bad news for everybody because it's too hot to be livable. But other areas that it does expand that sweet spot. Malaria can be transmitted longer. So you have faster transmission and you have longer season for it to transmit. And just so you know, these are predicting out to 20. So this isn't something that is predicted to be happening in a couple of years. So it's really, really far into the future. They show this graphically, and they just focused on the African region. And so they modeled out the total increase in nation at risk, and then the person months at risk. And you can see it's going down, and some are going up. And so they modeled this out and showed the results of their 4 models for the 2020s. Like I said, nothing's changing right now. The 50s, where you see this increase, and the 2080s, where it bumps up a little more. And these models are really interesting and really complex and really cool for thinking about what's going to happen in 60 years to malaria and its expansion globally. But if you're the national director of a malaria control program right now in a country that is experiencing the effects of climate change and that it's impacting the success of your malaria control program, these aren't really that helpful for you today, right? And so what is happening today that is being by many countries and many malaria endemic countries is an increase in severe weather events directly associated with climate change. So not that it'll increases in temperature, but actual severe and frequent weather events. And so if you're into this, there is actually a Center for Research on the Epidemiology of Disasters. And put out annual reports on this. Great for lectures like this. And so we can see that in 20 we saw an increase in the annual average from the year, and they have tracked annually that there have been these increases. It changes in type of event, but in general, fairly large increases in severe weather events. And I'm not minimize all the other ones, but and severe storms are kind of the biggest, and there's lots of them. And this has even gotten the attention of the IMF because this has big economic consequences when you have these types of severe storms. And they model, it's hard to see, it's really not that important, but they modeled out how the severe, different types of disasters over time, and they did it by level of income of the country. And so just on kind of like which countries' income levels are going to be able to respond to this and how economically impacted are they going to be. And they show that lower and middle-income countries are going to be more impacted. And I really like this Venn diagram, and that was put out by the International Panel on Climate Change, because they separate out just the climate event, that weather or climate event, that storm that happens, and how that becomes a disaster isn't in isolation, right? Right? You have the vulnerability of the community and the exposure of the community. And the vulnerability factor could be that if it's a country, may not have the resources to actually respond at it. And when you take exposure, as humans, we're good at being exposed to the elements, except for tech. We're bad, right? If we don't have housing around us that are built with really good walls and really good roofs, right? We don't do well if it's strikes. So if you can do account exposed populations that are vulnerable and then a disaster strikes, you have, or then a weather event strikes, it really counts how bad that disaster. And one really good example of this is what happened in Mozambique in 2019. So this was March 2019. I was just there in January of 2019 to assist my collaborations to set a research site. And then Cyclone died. And it was really devastating. And so this is an article from Nature, just a few days after it hit. Say that here is Cyclone died, and here's why it is one of the most devastating storms ever to impact the southern. And just for reference, this picture is the impact afterwards. But this is the second largest city in the whole country. And this, the picture of what it looked like in that aftermath. It was completely destroyed. And so they kind of put the numbers to it, and this is after the storm. So these were estimates, and they did go up substantially. Of the number of people that it is now estimated to be over 2 million. And the number of deaths, which is well over 1,000. It was really actually quite difficult to reconcile those deaths because of the nature of the specific storm. And so this is Mozambique, okay? Borders on the Indian Ocean. And so what cyclone had done that made it so bad is that it made two landfalls to start with, making it have a huge area impacted. When it did first impact, though, it was only tropical and didn't even have a name. But it turned around, went out to the ocean around Madagascar and gained a whole bunch of speed. And it impacted as an intense tropical cyclone in a major city, in a major port city that's of river networks that feed into the city and very low elevation. And so there was massive, and it was really strong and just barreled through the middle of the country. And it was big. It dropped a ton of rain. And then it reached a mountain range. On the border between Mozambique and Zimbabwe, there's huge mountain range. So it increased, you have a dramatic increase. And in this particular year, it was also the year of a very severe drought. So the ground was really dry. And so when you hit the side of a mountain with a lot of rain during a drought and dry land, you get muds. And along that mountain range, there are villages. And so those mudslides basically destroyed all of those villages, and it became really difficult to actually recover anybody from those areas. This was a huge scale of devastation. You just see that the area in blue is the hardest hit area. It's over half the country. And of like just the affected area in the light blue. So it's a huge impact. And Mike had a really hard time. It's really in the best circumstances, it's hard to provide to over half of your country impacted by a storm like this. So the record was really rough. And aspect that was highlighted as really impacted was access to healthcare, right? And so this study looked at the road quality in the access of healthcare. So looking at road networks in the most impacted area. And so the graph B shows health access in a normal situation. Highlight that all of the purple area here, which is it, is greater than 6 hours to healthcare facility. So it's not great in a normal situation. Best case scenario, you're in one of these 2 to 4 hour ranges. Normally. After the cyclone hit in this graph here, that increased in most areas by over hours. So you're going from a bad situation to an impossible situation. However, in gray, they didn't even bother modeling because they just don't have healthcare access, right? This didn't get resolved. This was a very long recovery. And spoiler alert, another cyclone hit 2 months later. You have this cumulative level of damage that is really hard to recover. And on top of that, Mozambique of malaria. So this is a map of Mozambique with the cases per population. And so they have the 4th highest cases globally, 4th highest mortality globally, and they are incredibly resource constrained. And so nearly half of the population of Mozambique is below the national poverty line. And the national poverty line that's not the global scale of the plan. So a lot of resource in this country. And really important if you are in a malaria endemic country, access to healthcare. It's really easy to diagnose. There's a rapid test. It's really easy to treat. A 3-day course of pills that cures the infection. And so it's really easy, but if you don't have that access, because that has to be provided by the healthcare provider, bad situation, because it's recommended that treatment provided within 24 hours of symptoms of malaria, because once you have symptoms, it can get severe very quickly. And so in terms of malaria, there's a national heterogeneity. So it's not distributed everywhere. In the south, where the kids, it's fairly low, and they get rid of it there. And then it increases further north. And you look at the scale here, this is the prevalence. In the darkest area, the parasite over 80%. So it's a lot of malaria. And so there are interventions. The National Malaria Control Program, several interventions. So in the southern region where it's low, they have indoor residual spraying, so spraying the walls of households with insecticide to kill the mosquitoes. Insecticide treated distributions universally, so everybody can just get them. And then that's where they're to the elimination phase. But north, where it's really bad, they have the insecticide. They have the ITN district, the bed nets, but mainly through care centers, because malaria in pregnancy is worse than malaria generally. And they've piloted also ITN distribution through schools, because it's really bad also with kids. Targeted insecticide treated net distributions. And then for the rest of the country, it's ITN distribution through the antenatal care center, case management, so making sure that healthcare facilities are equipped to handle this, establish and maintain a support system, which they've actually done really well at. That's where it's come from. They did, which is kind of cool. They did mass ITN distribution in the province in 2020. And that was coincident after we presented our results from our study to the National Malaria Control Program, showed them that the coverage of ITNs within our study area was 37%. And so it did cause them some concern. Okay, and so this is our study, the one that I went to try to start up right before cyclone. It is an area that is within the path of the cyclone, and we're really interested in setting a study in Susandenga. So this is Susan. Gonna get confusing. Our study is in Susandenga village, which is in Susandenga ward, within a district in Dominica province. So we just call it the Susandenga study. And so it's in addition, is right along the border of Zimbabwe. So you have a lot of different ecologies there, a lot of different elevations, but it's still a local area. And there's a lot of movement between Zimbabwe and Mozambique along that border. It is a completely open border, so you're allowed if you're Mozambican or Zimbabwe, not if you're American. But you can move completely open. And so this is a map of where the actual village is, along our roadways, which was part choosing because it's accessible from Moyo, which has an airport, so we can get there. And so we set a cross-sectional survey as a pilot study. And so we did it is Dominique added the heavy lifting of using Google Earth to enumerate every single household within the village, and then we could take a geographically random sample of 120 households that we were going to go visit and invite to be in our study. And so we're able to do our study from November 2019 to February 2020. Our data collection ended right before the pandemic. So we were really fortunate with cyclones and a pandemic. And so we did a household level survey with the head of household to measure the household structure and cyclone damage. We want to get into some questions about the cyclone and the impacts within the survey. And then we did individual surveys with everybody else who resided in the house about their perception of malaria, demographics, their healthcare access, and their use of the health facilities and informal health facilities, their access and use of preventive measures, and we did a rapid diagnostic for malaria. And within our study, the prevalence of malaria was 30. And that's with us going out and testing people actively. And this is another challenge for malaria that's talked is that in endemic areas, individuals have been exposed to malaria a lot, gain immunity to the cleanse, but not to the parasite itself. So people, once they have that immunity, if they've grown in age and suffered many severe malaria episodes, they can become infected, they can transmit, but they're not symptoms. And so they're really hard to if you're trying to get to that elimination phase. Susan Dega is there. Yeah.
So how long particular infection lasts? Like if people are just getting infected every single thing like that?
I don't know the rapidity of the infection. Yeah. Other studies, and I did one on the parasite genomics. People have different infections at the same time, and they can last 10 years. It's been the longest kind of documented, but it's hard to tell because they're affected with multiple different parasites, and it's just totally different topic. But because of the sexual, asexual, reproductive phases, parasite genetically, it's to try to detangle all of that to get its signature and try to determine the related parasites. If it's one and it's been maintained for, or is it one that's similar? It's pretty cool. But yeah, yes, they can be combined and carry multiple different infections. Yeah. Okay, so we wanted to look at housing and how housing impacts malaria. And there's a variety of different types of housing. Some more very traditional housing with thatched roofs, open windows, brick walls. Some more modern type of housing, zinc roofs, asbestos roofs, and there's a variety of windows that can't open, whether or not the gap between the wall and the roof, but that's open or not, because in a lot of tropical climates open because it permits airflow, and it also mosquitoes get in your house. And that the parasite prevalence by housing structure, and we kind of in different categories of modern or rudimentary different construction material. For the roof, the walls, the floors, the windows were able to close or not, or whether the eaves were open or not. And in our study, most people had modern roof. So it does end up looking in this kind of distribution that modern roofs is really associated with infection. Spoiler alert, it wasn't. But we do see it looks like a relation between the floor structure, the windows, the eaves. We modeled this out, and one hypothesis that we had was that, this is, it's all like complex, but the head of household occupation and education, kind of like the social status of the household was actually driving things, and then this relationship was being mediated through the structure. So it wasn't just the housing structure. We tested for that, and we didn't see it at all. So we just went and adjusted for patient and education of the head of household as a kid, as well as other individual demographic features. And so was that essentially all of the different housing, our rudimentary housing structure for all that we looked at, except for open eaves, was associated with an odds of malaria infection amongst the residents living in the six households. And this isn't incredibly new. First studies have shown that housing is really important for malaria infection. But we wanted to take a look at our study, and what it is kind of new, we saw it across the board with all of the different housing structures. So usually it's isolated roof or just floors or just windows. Seeing it with all of the different types of housing in this community. So housing here is really got me thinking about, well, housing is really important. What about the damage to those houses when the cyclone came through? Because there's housing damage. So we measured that. We were actually able to capture it on our survey, and this is looking at just percent positive, malaria positive or negative by housing type or housing damage. So most of the houses in our receipts they had some type of whether that's significant or being completely destroyed. And it's important here that we asked and the households had received any to actually repair this damage. And so our survey, they were still in the process doing those repairs themselves. So they were currently living in damaged houses. And it had still been a while, 9 months since the cyclone. But it's really hard to repair. It's been destroyed. And so we wanted to look at the housing damage and its association with malaria. And so this model, we accounted for the housing structure. We still found that particularly damage and having your house destroyed is associated with an increase of having a malaria. And so we thought, okay, well, yeah.
You may have said this, is the, for malaria, for your outcome, is that anybody in the household, that head of household?
So these are GE models. So it's, the individual, are the analysis, and then the cluster is the household. So they all have everybody in the same household has that exposure. Yeah. So so we know that housing is important, that house is there, that's incredibly important in an area. We wanted to think, like, how can we do this on a larger scale? Because it's a really small village, we didn't have a great sample size to actually say, like, this is a big deal when it's, so we thought, oh, bigger. And so we're still focused on cyclone and dive, but we wanted to look at the underlying damage that we could detect at the provincial level. And so I had a really great MPH student, Calder Glowak, who actually did a lot of the legwork for this, and using Google Images to go and track the destruction based on the roof of health, focus on health facilities and schools, enumeration lists, and we knew where they were. And so this is just a set of three different health facilities for the cyclone. And after the cyclone, you can see the roof damage. And this one is blurry, but the roof is gone. And then track into the future to see how long this takes. And some of them never got repaired, and some got repaired. Some it took years to repair. And then we did the thing with schools. So going through and tracking what the roof looked like before, what happened after, and then how long it took to repair. We're going to quantify this damage, the proportion facility. So this is Sofala province now, the most heavily impacted. This at the district level, this is the highest impact because it's just that's where over 60% of their facilities were damaged. And we had malaria data from sort of the national surveillance where we could look at the association between these two. So we had the malaria percent change from 2018, severe malaria incidents, and preventative treatment during pregnancy as a marker for access to care. And so we fit a sonar for this to look at the association. We have a few confounders in there, but this is logical, right? So we're pulling everything like that, and land use data and things like that. But in districts with higher facility damage, we saw an increased risk in malaria incidents that year, and also an increased risk in severe malaria. And so, a pretty cool story here, because we have that household level, that individual household, we've got the larger infrastructure, and trying to build on it. And then a call came out from us about digital technology development for climate-sensitive infectious diseases. I have a climate-sensitive infectious disease that I research, but it has a specific call for solvers. I'm not a software developer. I'm a software user. I know a software developer. I have an idea. And so I put together a team. What?
You're allowed to cheer it up. Go for it.
So I put together a team, and I was bolstered in my confidence because, you know, a lot of models are like the ones I showed in the beginning, like these small changes over time. But on the call, they had a picture of a cyclone. I'm going in with this focusing on storms. They're gonna love it. And so we go in, we put together a result that we thought was like, this will be easy, right? And so we wanted to create a software-based analysis platform that identifies of high malaria risk, increase the efficiency of control programs following severe weather. And so the whole thing is to get a bunch of environmental data and storm data, and then we're gonna get a bunch of malaria data, and we're gonna put together a model. And then we're going to build a software that then can show the results, and a policy can use that to say, hey, here's to put my bed nets because they've probably all been destroyed by this storm, and protect people from malaria. And so we're collaborating with people, and luckily we have a really good collaboration with the National Malaria Control. So they have given us access to all of their surveillance data, and their guide how we've developed this, what they're actually interested in, and what scale they're going to see it on. And so everything is at the district level. So it says case rate, but I had a biostatistician put this together, so it's incorrect. It's actually proportion of malaria cases per population at risk within the district. And you can see there's a lot of heterogeneity. You can see that across southern area where they're trying to get to elimination. But where it's bad is bad. And the scale. It's good to always look at the scale. Where it says it's good is like 25% to 50% of people with malaria that year. And in the bad areas, it's over 100% because of what Rachel brought up. People can just keep getting infected, and they can go multiple times. There's no full sterilizing immunity here. And so we put together this database of named storms. So named storms are your tropical storms and your cyclones named from the World Meteorologic Database or World Meteorologic Organization. And then go into the database and have some information, mainly their wind speed and where the eye of the storm will track. But storms that are under 39 miles per hour don't database. So this is just the named ones. And this is for Mozambique. In fact, we're only investing this end. But I went back just to kind of show what the trend has been. There's this nothing statistical seeing that there has been an increase. But if you look at it, cyclones and when we think of hurricanes and other severe storms, they're rare events, right? And Mozambique has a cyclone. It's not uncommon to have a cyclone and have been historically, sometimes two, but with these large gaps between. And that has not been this 2019. Right, there's been at least one cyclone every year, and in most years two, and in really bad years up to four. This year, where we're in, there's already been two, and right now, currently, massive flood and half the clear water. So it is experiencing devastating climate events. Now, this is a movie. So what I said is that there's some data that comes with these. And so this is a die because they're all documented and of what happened in terms of tracking. So what we can do is we get, this is every 6 hours, so it's a really fine scale. We can take kind of these storm tracks. There's a gap, but it's okay. We can take these storm, a lot of missing data within these databases, track where it went, right, where the eye went. What it doesn't tell you is how big that storm was and how much of the population is impacted. It just says went, basically where the middle of it went. But we can use that to get kind of a reference are these named storms, and we track them, and then we can use the precipitation data from NASA to then actually estimate how much of an area was actually impacted by this storm. It's going to come back in the middle. There you go. Yeah, and so then we can use and estimate how much precipitation fell, how much of the population is impacted based on the diameter of the precipitation that followed that storm. Link that together. Then we can also link together the temperature, the wind speed, and the barometric pressure, all of the variables that go in types of storm. And because all of those data are publicly available. And that's for named storms. And we're using that to kind of develop how we're identifying the area of risk, how many people are at risk. There are unnamed storms, damage, right? Just because a storm has a wind speed of 37 miles per hour doesn't mean that it's not safe, right? There are other events that we're actually, because when you download like all this weather, you get daily data. Like it doesn't, it's just my storms and here's my not storms. It's daily data. And so we can use that to go and actually identify when there's a non-average. So when, say, the precipitation veers off and determine if that storm and what the population is impacted by that storm. So we have a more comprehensive database that we're using. And it is a lot of data to put together. In all different formats and all different resolutions. And then our malaria data is all at this level. So it's a lot of data decision making. And the modeling is getting pretty complex. But even for the simplicity of how we propose to, and I'm really fortunate to have a fantastic team that's capable of put all that together here and biostats and computer science, actually organizing this and constructing models. And working closely with the National Malaria Control Program so that everything that we produce is actually usable for them. It doesn't just kind of go into like writing a paper and then that's it. We created a software that nobody uses, that they actually can use this. And the goal is for them just take everything over and run it and be able to troubleshoot it and train their coders. And they're actually coming here in June to learn that, which is really exciting. And then we actually, I didn't mention it in here. There's another part of that study that's going every single province within the doing household surveys on the level of household damage that was incurred during whatever that storm was. And so we can actually add a level of what is the damage incurred, not just that there was a storm, but what is the level of damage that happened. And that team is from the is based in Mozambique and also is doing a lot of work facilitating our work with National Malaria Control Program. And then this all came from my team in Susandenga that did all the work at getting that first study off. We could actually look at the housing and how housing damage was associated with malaria. And that's the center in Susandenga, an impressive one. They have beds. Okay, so I'm there.
Thank you so much, Kelly. Do we have any questions? Really wonderful presentation and the modeling seems like the contribute to have a lot of potential. I know in the US, some of the health insurance companies, they've done much to predict how much damage is by storm. Ahead of time, they can know how many insurance adjusters they need to send in. Have you looked into the what kind of models or?
Yeah, I started those, and a lot of those are very economic based, but they're useful and like what they cost. But what I actually got most or some of really great information from was through roofing companies that because after you have a storm, typically a hailstorm in the Midwest, they go out and they can identify which area are going to have the most damage, and then they come and they're like, would you like a roofing estimate? So they have really good models at identifying kind of from a roofing perspective, where are the hardest hit areas? So.
Thank you. Great talk, Kelly. I did notice that the Ministry of Health has a machine gun.
Oh, that's flag.
Oh, that's our flag.
Yeah, it's
Okay.
the state,
Well, that's
where
different.
it's the country emblem. It's the only one I find.
But I do have a question here. You know, one of the points you made was the housing is basically open air and things get in. Quite the opposite in my experience in Nigeria, where the houses have tiny windows of wards and slavery, and they didn't want to let people in. They have with that high level ventilation. So what is the balance here? I mean, West Ham also has.
There's a lot of malaria. Yeah.
I had it as well.
Oof, that's rough. I've never had it. It's interesting because there's a variety of housing, and so look at across different types of housing. If housing structure still kind of holds that it's really associated with malaria, it's associated can be associated with TB, doesn't allow for airflow. So I don't know where the sweet spot is, because a lot of the more traditional housing, which may increase malaria risk, is used cooling, right? Even eaves and arched roofs and mud brick walls, those are very cool. And then when you have if you have a simple zinc, it is hot. Even though it provides that protection from the elements. And so one method that's been mentioned how to resolve this to allow that airflow, but then also provide protection is screens. And so for houses that have windows, providing the material to put it on that window, even if it's like an open closed, and to have a screen for the door. And even if the eave is open, have a screen for the eaves. So take advantage of the cooling, but then adding a border effect that the can't get in. Yeah, but I don't really know where the sweet spot is, because it's also housing structure is very dependent upon the community and what they use for their housing structure. And so, yeah, I don't know what the resolution is.
The other issue as well is cooking and smoke inside the house. Bad for babies.
Bad for babies, things and other people. In Mozambique, that is, I don't want to say all, most of the kitchens are outdoors. And so there's the sleeping structure. It's where people sleep, and then there's structure, and there's the communal structure where everything's outside. Well, we're very because they're outside and mosquitoes are there.
I have sort of a related question to Russell's, which is about the strain of the walls. So it seems like there might be sort of a health cost involved with that. Is the protective effect for malaria really offset any concerns around exposure?
So the insecticide on the walls, there hasn't been evidence showing that there's a health impact. So how it works there is kind of a pain for whoever's getting their house. The government shows up with a team and they have their sprayer backpacks, and they have masks and stuff. But then they tell the people in the house, hair spray, can you please remove everything from, and so everything has to go outside. So they have to the family has to take everything out so that it doesn't land on it. And then they wait for it to dry until they go back in. And so even when they do testing to see how long that lasts on the wall, because it dries, so the family can't go back in if it's aerosolized. So you're not supposed to breathe it in when it's aerosolized. Once it's dry, it's considered safe. To take a sample of it, you actually have to scrape off part of the wall. But another point to that is if your house floods, that protective ability of that insecticide is So when you have these cycles, like people lose their RTNs, they lose any protection they have. The National Malaria Control Program is really interested in it because it's really, this is really hindering their ability to like have the successful control.
The increase in the frequency of the rates in particular, what has been done or what is being done, or is your models helping to inform of standing water, or is that sort of external to this?
Right, but what is being done, so there is a disaster response unit within the government that provides all the responses, and those responses when there's an event like that, like first and foremost, like injury, cholera prevention. And then if there is, if it's relevant, any life support, and then maternity wards. And so they're focused really on that urgency. Outside of that, I mean, there really is no other.
So like, would you use these models? Like, I'm assuming the increases in water in buckets and then
Right.
some people's structures add to more of those breathing,
Right.
like independent of temperature or related to the temperature.
Yeah, so we
Can
can
have
yeah.
pellets that we can spend like, that's what we said here, right?
Right, like, it would be great, like that right now, and with the satellite imagery, so we know like the precipitation. With satellite imagery, we can look at it and we can tell like go take a this area and we can see where there have been puddles of water. If they're at a certain resolution, as large as the house. The smaller scale standing water, it's really hard to measure. I mean, it could be something that we could do a drone. To go out and like where there's standing water, but it's something that unless going out like in person and observationally, it's really hard. And when you have those events, it's hard to go out there observationally because there's also like flooding of the roads. But with that, that's also why we will usually try to measure like how people perceive malaria and risk and the different kind of factors. There are a lot of public health campaigns around malaria that are like remove standing water, like, you know, don't keep your water in buckets or cover your buckets and things like that.
Well, it is a look. Thank you so much for a great presentation, Kelly.
Thanks for
And
letting me.
thank you everyone for the seminar. I hope to see you next week.